Welcome to today's Explainer. We are jumping right in today because we're taking a deep dive into an absolutely fascinating and frankly, crucial topic in women's health. We are looking at the revolution of using objective imaging, specifically ultrasonography, to diagnose lipedema. For way too long, this condition has been a complete mystery, diagnosed mostly by clinical observation and, let's be honest, guesswork. But today, we're going to look at the hard data, the exact measurement cutoffs, and the cutting-edge technology that is literally changing the game for both patients and clinicians. Okay, let's dive straight into this. Why is endometriosis a condition that affects nearly 11% of adult women worldwide still so frequently misdiagnosed? The stakes here are incredibly high. Just think about that number, 11%. Yet it remains one of the most misunderstood conditions in modern medicine. Patients are so often subjected to unnecessary medical interventions or told that extreme diet and exercise are the only answers. We desperately need an objective diagnostic tool to break this cycle of misdiagnosis, and that's exactly what we're unpacking today. Here's our roadmap for today. We'll cover the diagnostic dilemma, then the ultrasound protocol, followed by diagnostic cutoffs. After that, we'll compare lipedema versus lymphedema, and finally, wrap up with shear wave insights. Let's get right to it. Starting off with Section 1, the diagnostic dilemma, a history of misdiagnosis. So, as you likely know, lipedema is an adipose tissue disorder. It's characterized by this disproportionate, symmetrical accumulation of nodular fat, primarily in the lower extremities. Women in the later stages often present with that classic column leg appearance. The real tragedy here is that, despite these very clear physical signs, lipedema is incredibly resistant to traditional weight loss modalities. Because many physicians just aren't completely aware of the specific pathology, patients with this painful fat deposition are frequently dismissed and misdiagnosed with lifestyle-induced obesity. Now, what's really interesting when you break down the differential diagnosis matrix, comparing lipedema, lymphedema, and obesity, is that a few specific clinical signs really stand out. Take the stemmer sign, for instance. In lipedema, the condition famously spares the feet, meaning you get a negative stemmer sign. That's entirely unlike lymphedema, where the skin on the toes actually thickens. Furthermore, lipedema is highly painful to palpation, whereas lymphedema and generalized obesity typically aren't. But while these clinical signs are definitely helpful, they're still kind of subjective. We need something a lot more concrete. Which brings us to Section 2, the ultrasound protocol, setting the standard. If we want truly objective data, we absolutely have to have a standardized protocol. The research clearly highlights the technical requirements needed to make this work. We can't just use any standard ultrasound machine. The protocol specifically mandates using 7.5 to 15 megahertz linear transducers. That specific frequency range is the absolute sweet spot because it provides incredibly detailed, high-resolution evaluation of both the skin and the underlying subcutaneous tissue layer. With this precise equipment, clinicians aren't just looking at the anatomy. They're accurately measuring tissue thickness and echogenicity, which is basically how bright or dark the tissue appears based on how it reflects sound waves. But, where exactly do we point the probe? Lipedema presents in several distinct distribution patterns across the body. You've got the saddlebag phenomenon, folds around the knees, distributions extending right down to the ankles, and sometimes even involvement of the arms. Because the fat deposition is so localized and follows these specific patterns, our ultrasound evaluation has to be highly targeted. You can't just measure randomly. You have to measure in standardized zones to get accurate comparative data. To solve that, researchers have standardized 4 key measurement zones on the lower extremities. Those are the anterior thigh, the pretibial region, the lateral leg, and the supramalleolar region, which is just above the ankle. By consistently evaluating these 4 exact anatomical points, clinicians can finally obtain accurate, reproducible readings across completely different patients. It completely removes the subjectivity that has plagued this disease for decades. Moving right along into Section 3, diagnostic cutoff values. Let's look at the hard data. So the crucial takeaway comes down to these exact, validated numbers. Through really rigorous study, researchers like Dr. Amato and his team have established highly accurate diagnostic cutoff values for subcutaneous tissue thickness. If a patient's fat layer exceeds these specific measurements, it is a massive, objective indicator of lipedema. Just look at these numbers: a cutoff of 17.9 millimeters for the anterior thigh, 8.4 millimeters for the lateral leg, and a remarkably accurate 11.7 millimeter cutoff for the pretibial region. That pretibial measurement in particular, it has shown absolutely excellent diagnostic accuracy. To really put that into perspective, when observing these measurements with a digital ruler in a clinical setting, you're seeing the exact thickness of the skin and the subcutaneous fat layer mapped out. This isn't a doctor just looking at a leg and making a best guess. This is precise, millimeter-accurate data. When those measurements hit 11.7 millimeters on the pretibial region, the clinician has objective, undeniable proof to support a lipedema diagnosis, completely regardless of the patient's body mass index. Let's transition to Section 4, lipedema versus lymphedema, the sonographic hallmarks. Let's contrast the two conditions. In lipedema, the true hallmark sign is increased thickness of the subcutaneous fat layer, combined with what we call hypoechogenicity, meaning the fat literally appears darker on the ultrasound. Crucially, the dermis, the actual top skin layer, is completely preserved and normal. Lymphedema, on the other hand, is the exact opposite. Lymphedema damages the dermis, causing significant skin thickening and dermal hypoechogenicity, and you'll actually see pools of anechoic interstitial fluid or free fluid trapped right there in the tissues. And evaluating high-resolution ultrasounds side by side brilliantly illustrates exactly what I mean. When looking at lipedema, you can clearly see that thick, dark, hypoechogenic band of subcutaneous fat. It's noticeably darker than normal fat because of the altered tissue composition, yet that bright, thin line of the dermis right above it is perfectly intact. If this were lymphedema, that top skin layer would be thick, swollen, and you'd clearly see dark pockets of fluid below it. To really solidify this, let's look at a definitive quote from the literature by Mayfield and colleagues. They state quite clearly, "Lymphedema appears to be associated with increased skin thickness. Conversely, lipedema may be associated with increased thickness and hypoechogenicity of the subcutaneous fat." This completely confirms that ultrasound isn't just measuring size, it's actively differentiating the deep structural pathology of two completely different diseases. Now for our final topic, Section 5, shear wave elastography insights, connecting the tech to the pain. Enter shear wave elastography, or SWE for short. This is a novel, cutting-edge, completely non-invasive ultrasound technology. While your standard ultrasound measures the thickness of the tissue, SWE actually measures the physical stiffness and elasticity of the tissue by sending shear waves right through it. It gives us a real quantitative measure of just how fibrotic and rigid that fat has actually become. It's a real game changer. And here is the massive breakthrough. Recent studies, like the one conducted by Yaman and colleagues, have shown that the tissue stiffness measured by SWE in the thigh directly and positively correlates with the patient's actual reported pain scores on the visual analog scale, as well as their neuropathic pain scores. This is just monumental. It means that the structural stiffness we can clearly see and measure on a screen maps perfectly onto the physical suffering the patient is experiencing. We're literally bridging the gap between cold clinical imaging and a human being's actual pain. So let's quickly wrap up with the key takeaways from today's explainer. Lipedema is no longer an invisible or purely subjective disease. It's a structural, objective condition that is highly measurable via ultrasound. To do this correctly, we must use a standard protocol requiring 7.5 to 15 megahertz linear transducers. By using validated cutoffs like that 11.7 millimeter mark on the pretibial region, clinicians can virtually guarantee diagnostic accuracy. And finally, shear wave elastography validates the patient's experience by perfectly correlating tissue stiffness with actual measurable pain. Which leaves us with this final thought-provoking question. With these incredibly powerful standardized objective imaging tools right at our fingertips, tools that can literally measure thickness, density, and even stiffness related to pain, is it time we finally retire the purely clinical diagnosis of lipedema? It's a question every single practitioner should be asking as we move forward into a brand new era of understanding and treating this condition. Thank you so much for joining me on this deep dive, and keep learning.